Hi everybody. Today we'll be looking at probability, odds and Bayes' theorem from the perspective of me, a clinician, and how we can use it in clinical practice rather than the usual bog standard spin and snout that is touted all the time from people who should know a lot better. There are two major ways of estimating chance: probability versus odds. So probability is more intuitive, and it's sort of the chances of, out of say 100 spins of a coin, how often that will come down heads, which would be on average 50-50. So it'll come down 50 times heads, come down 50 times tails, and that would give you it. So it's a fraction of the number of times you expect to see it. So you could say that this is a percentage. So in this case, it would be a 50% chance of it coming down heads. Odds, on the other hand, is a ratio between two numbers, and the two numbers are the chance of it coming down heads and the chance of it coming down tails. In this case, the odds would be 50 times heads, 50 times tails, 50-50 or 1-to-1. So probability can only go up to 1 or 100. So it can either be 0.5, 0.75 or 1. Odds though can go from 0 to infinity. You can have 99.999999999 to 1. Both are used. As I say, probability is more intuitive. If I say it's got an 80% chance of this happening, you have an automatic feeling for it. If I say there's 4-to-1 odds, then it's going to happen 4 times and against once. So it's a little less intuitive, especially when you start looking at fractions. So it's 0.75 to 1. This gets less intuitive, but odds are useful when we come to talk about likelihood ratio. So both are used. So sensitivity and specificity, you learn about these in school. I'm not going to go into how they're calculated from raw data, but these are probabilities. These are usually given in percentages. What is pitiful though is when an educator talks about spin and snout. Specificity rules it in, sensitivity rules it out. And while this is sort of crudely the way these work, it's really not good enough for us. There are reasons to look at this. So X-ray protocols, for example, is much more important that the sensitivity is high. Whereas if you're looking at accurate diagnosis, then the specificity is more important than the sensitivity. But to say spin and snout is really, it's crude, it's pitiful, and if this is all they're giving you, that they should be ashamed of the spell. Especially when you consider the people who are mostly teaching this have PhDs and know a lot better than that. Just to give you an idea, this isn't something you're going to be doing, but to give you an idea, you can convert probability to odds, and you can reverse the conversion odds to probability. And this is just formula for doing it. There are times when it needs to be done, not necessarily by you, but for example, if you're dealing with probability, for likelihood ratios, these probability need to be converted to odds. Now you can do these by hands, and it's not a difficult calculation. Or you can use a nomogram, which we'll talk about a little later, where it's basically done for you. And it also additionally helps in the form of including your anterior odds of a thing happening. So it's not necessarily for you to do this, but it's just as well that you would understand how to do it, or at least how it's done. Okay, so likelihood ratios are odds ratios, and what they do is they combine the sensitivity and specificity converted to odds, give you an idea of how well a test works, better than do sensitivity and specificity values taken as raw numbers. The conversion of probability to odds takes place as you calculate the likelihood ratio. But the likelihood ratio, once you see it, is actually quite intuitive. As far as numbers are concerned, it's easier to see a single number than looking at two and trying to decide what's helpful. And we'll look again at that a little bit later on. I'll give you some examples of that. So technically, a positive likelihood ratio gives the odds on a condition being present when the test is negative. Okay. So the higher the likelihood ratio, the better the test is, in as much as it's much more likely the condition is present when you have a high number rather than a low number. Now, as I say, these are odds ratios, so the number can go anywhere from 0 to infinity. So you can have some very, very high likelihood ratios, which indicate extremely good tests. The negative likelihood ratio reverses this, and gives the odds on the condition being absent when the test is negative. The lower resulting number, the better the chance that the condition is absent. So now you're looking at a very low number, and I'll give you an idea of what these numbers look like in a minute. But the calculation isn't very difficult at all. The positive likelihood ratio is the sensitivity divided by 1 minus the specificity. And it's that 1 minus the specificity that converts this to odds. The negative likelihood ratio reverses this, and it's 1 minus the sensitivity divided by the specificity. So this will give you the likelihood ratio. Now, if the likelihood ratio is not given, it's easily calculable from the sensitivity and specificity. So there's no reason why you can't do this, even when that number isn't given. So at a quick glance, which I'm going to give you a few seconds to look at, which one of these three tests is the best for your patients? Okay. Not all easy to tell from a glance, especially if you're not used to using these. So a researcher may be able to do that, but it's unlikely that the standard clinician will be able to. But if you look at when we convert these to likelihood ratios, then it becomes much more obvious. Remembering that a likelihood ratio that is diagnosing the condition as being present, the higher the number, the better. This becomes really easy. So the first one has a positive likelihood ratio of 2.33, the second one of 3, and the third test of 2. So it's obvious straight away that test 2 is a better test. As far as negative likelihood ratios are concerned, the lowest test there is 0.33, which has the lowest positive likelihood ratio, and they are inversely proportional to each other. So as an overall test, test 2 is a better one. But if you're looking at as far as including things in such as X-ray protocols and so on, the screening tests such as Sharp's Fursa prior to manipulating the neck, then test 3 would be your better bet. If you actually thought that there was an instability present in craniovertebral joints, then test 2 would be your better test because it's more diagnostically accurate. Depends on what you want the test for, but it becomes obvious as soon as you convert this to likelihood ratio, which of those 3 tests will suit your purposes best. So, which is better, sensitivity or specificity? And you may have made out from what I said previously, it really does depend on what you're using the test for. But let's find out anyway. So, test 4, test 5, test 4, a sensitivity of 0.9 and a specificity of 0.8. Test 5, a sensitivity of 0.8 and a specificity of 0.9. So what I've done is reverse the numbers. But what you can see, what it does to the end result. High sensitivity and a slightly lower specificity, and it brings the positive likelihood ratio to 4.5. Whereas on test 5, where we had a higher specificity than sensitivity, the positive likelihood ratio goes up to 8, almost twice as much. And look what happens to the negative likelihood ratio. 0.125 where sensitivity is higher than specificity, and 0.222 where that's reversed and you have a higher specificity than sensitivity. So essentially what it's saying to you is that high specificity is good for when you're trying to diagnose something. High sensitivity is good when you're trying to screen something out. It come back to spin and snout, but it's more useful this way. And it makes more sense this way. You can see exactly how much snout and spin you actually have going on there. So if you're looking at a test to include things such as X-ray protocols and screening tests where you want to not do certain things to certain people, then a high sensitivity value is better. That will give you a lower likelihood ratio, which is what you want. If for diagnosis, though, where you are trying to make an accurate diagnosis, then a higher specificity is better than a higher sensitivity. Just remember this, you can have one test with a high sensitivity, one test with a lower specificity, and they will combine in the same way as a single test would. So there's no good reason why you can't use 2 tests, one of a high value and one of a mediocre value, and the other one reversing that order to give you the equivalent of one single good test. So it's a general worth. This table is opinions from researchers, and what you can see is that the higher the likelihood ratio, when it's a positive likelihood ratio, the better, and the lower when it's a negative likelihood ratio, the better. So values between 1 and 2 really don't make a lot of difference to anything, and it's really a fairly useless test. Values between 2 to 5 as a likelihood ratio, positive likelihood ratio, is pretty good, and is usable. And 5 to 10, you're getting up to a better effect, and not great neither. Once you get over 10, these things become really quite useful. On the negative side, negative likelihood ratio side anyway, 0.5 to 1 is not very useful. 0.2 to 0.5 can be useful, as we saw in the previous one. We had a negative likelihood ratio of 0.22 there, and you get up to more moderate amounts between 0.1 and 0.2, and then it becomes very useful after 0.1, lower than 0.1. So if you compare the previous tests, which I've done at the bottom there, to the numbers, it'll give you an idea of how good those tests actually were. So from everything we've said so far, really, tests 1 through 3 are not particularly valuable tests. And you really couldn't tell that from the sensitive and specificity value on first glance. You'd actually have to work through them. That's what we just did here. Whereas the likelihood ratio will give you that. And I think it's more intuitive than some of the other predictive, positive and negative predictive values. Anyway, none of them are particularly good. But there is one other thing. It doesn't matter how good the test is. If you're doing that on somebody who has almost no chance of having that disease, the test will come back negative. So you need to know the chances of that test being positive or negative as you go into the test, before you do the test. And these are called anterior odds or initial probabilities, but you really should be able to estimate that, and we'll talk about that in a second. So these tests are only as good as how likely you think that person is to have the condition. Bayes' theorem does exactly that. You have to estimate the odds of the patient having the condition, and you can get that from prevalence values or from your previous testing, which includes subjective history and objective tests. All of this comes together to give you an idea of what the chances are of this person having the condition. Bayes' theorem allows you to change the probability of that condition being present as more information comes in. A lot of this depends on how accurate the initial test is, but only to a certain extent. You'll see that you should be able to predict that reasonably accurately enough to use it this way, just from subjective and objective information you've made. And if you've got none of that at all, you can do it from prevalence values. How often is this seen in the population that you're with? So it's quite easy to estimate the pre-test odds or probabilities to give you a post-test probability or posterior odds. So you generally go with an anterior initial probability because you're getting this from, you're looking at this as a percentage, especially if you're using prevalence values. If you actually know, if you convert this to odds, it becomes anterior odds or pre-test odds. You can call it whatever you want as long as you understand what you're talking about to yourself more than anybody else. So you can then apply this to the likelihood ratio, which you've calculated from the from sensitive and specificity, or you've got from the article. And then you'll get a better value from the test rather than just the raw data of the test, which is only sort of a guide to how good the test actually is in general. So when you apply these initial probabilities or anterior odds, the posterior odds or probability becomes much more useful, given that you've already gone in there with an idea of how likely the patient is to know to have the problem. Now, for the most part, if you're working clinically, by the time you've done the subjective examination, you should be about 70% confident in what the final diagnosis is likely to be. Then your physical test will improve that and refine it. But going into applying the next test, you should have a good idea of how likely that patient is to have the condition, and then you can apply that to the likelihood ratio of the test. So let's look at estimating initial probability, how you do it. So without any other information from the patient, you can provide there's information on this. You can look at prevalence values for that condition in the population, preferably in the population you're dealing with. The more specific it is to that patient, the better it is, obviously. Because sometimes you're just the general probabilities. We'll do this in an example in a second. So you may have seen this type of patient previously, so you're getting an idea of just how how likely they are to have the condition. So the estimate of the initial probability isn't very difficult at all. Okay, so let's have a look at how this probability estimation works. It's really quite simple. At one end of the scale, you've got the condition is definitely not there, 0% chance of it being there, no probability whatsoever. At the other end of the scale, it definitely is there. There's a bit of bone sticking through the skin. You can't miss this, it has to be there. So the range is from 0 to 100%. You can't get better than 100%. Now, if you're looking at this and saying it's probably not that, then you can average this to around about 25% probability, which is 1 to, I'm not going to do it, but it's about 25% chance that the condition's present when you're pretty sure it's not. If you're pretty sure it is, then we can estimate this at 75–80%. And if you're not sure one way or the other it's got equal chances, then you're looking at 50–50. So for the most part, this is really as much as the estimate needs to be. You don't really have to worry about 27.5%, 32%, 87%. You don't have to worry about that. Get a rough probability estimation. Now the numbers in between the percentages are the odds. I'm not suggesting you use this as a probability to odds converter. It's not good enough for that. But the odds there are on the numbers between 0 and 25. So that 1 to 4 is 12.5%, and so on. But this is an example of how you can estimate. It's not difficult. If you can't do this, you really have to question yourself why you can't do this on your patients. You should easily be able to do this with a bit of experience. Not a lot, a bit of experience. Okay, so this is a likelihood ratio probability nomogram. On the left-hand side, you've got the pre-test or initial probability. On the right-hand side of this, it gives you the post-test probability, post-test probability. The line in the middle is the likelihood ratio. So what you do is basically draw a line from the pre-test probability through the likelihood ratio of the test, and where it comes out on the other side is the post-test probability. Bayes' theorem can be used, which is basically multiplying the pre-test odds by the likelihood ratio, or you can use this nomogram. Okay. Okay, so let's put this into a bit of practice. You've got two lines shown on there, the blue and the green. Let's look at the blue line first. Now, what we're going to do is we're going to say that the test that we're talking about has a likelihood ratio of 20, which is the middle column. And we'll say that there's a 5% chance that they have the condition, but you decide to do the test anyway. Now, if you run the line from 5 through 20 onto the right-hand column, you end up with a post-test probability of around about 50%. So that's a 10 times increase for this particular test. Now, that's quite a big increase, and now the odds are 50%, 1 to 1, even chance that this patient has a disease. Now, depending on how disastrous that disease is, that can be extremely high. For example, if you're thinking this patient has fracture, upper cervical fracture, and you have a test that can test that, and you now have a 50% chance that patient has that disease or condition, then you're not going to mess with it. You're going to fire it out to the emergency room and let them sort through it. Similarly with something like BBI, where the consequences of you being wrong are disastrous, you'll get that patient out and to the emergency room at a 50% chance. But let's say we start off that there's not much chance of this happening. We'll say it's a 2% chance this patient has a condition, and then we can run it from 2 through 20, and we end up somewhere down around about 4% chance that this patient has this condition. Now you've got a problem on your hand. You have a problem. You have a thought to make. Is a 4% chance high enough to worry the patient and send this to the emergency room, or will it wait for you to send it to the physician, or can you ignore it? So what you see is it's still a big factor conversion. It's gone from 0.2 to 5. So this is well over 10. It's 2.5, 20, 30 times higher, whereas the previous one was only 10 times higher. So although the increase in your post-test probability is really quite high, it still ends up with a post-test probability that isn't very high at all. So if this isn't a condition that is particularly life-threatening, then you can ignore this and assume that that condition's not present. Of course, it begs the question is, why the hell did you do the test in the first place? Why are you applying a test to a condition that you don't think is present? Now, that sounds silly, but in fact, this is the way a lot of people talk. You do every single test you can think of and every single patient who comes in. And this is some of the consequences of it. You end up with a positive test that has very high validity numbers, but very low post-test probability. Now, what do you do with it? So ideally, the test should be aimed at the condition you think is present, unless you're trying to exclude something that's serious, such as predevelopmental instability in the Sharp-Person test, in which case 5% is reasonably high, even though you don't think patients are likely to have it simply because of consequences. It would certainly stop me from manipulating the neck if I had a positive test. How panicky I would get about it, how I would go about this is something different. I'd probably get a second opinion on this rather than saying, okay, this test is my probability of this patient having the test as being positive, and the test shown as positive gives me a high post-test probability. I'll fire that back to the emergency room. So you need these anterior odds or initial probabilities, or if you like, pre-test probabilities and odds, in order to apply the test properly, apply the results of the test correctly. What Bayes' theorem does is essentially to allow you to revise your predictions on the condition as you get more and more information coming. So this is all it does. And to basically calculate that, the initial probability is converted to odds multiplied by the likelihood ratio and then reconverted back to probability, or you can leave it as odds, depends on which way you want to do it, but generally speaking you always talk about probabilities. So it's really just a multiplication of the converted probabilities by the likelihood ratio, nothing difficult. Bayes' theorem, as I say, is a way of improving or updating the probability of an event or an occurrence. So basically what it is, the odds after you do the test, a positive test, equals the anterior odds or the initial probability, either way, in odds times the likelihood ratio. So if we were given a value of 4.33 to 1, then that's not particularly intuitive. 4 to 1 might be, but 4.33 to 1 takes some thought. So if we convert that back to probability, that will come out at 82%, much easier to understand. So let's look at Bayes' theorem in use, and we'll apply it to the Sharp-Person test. This test has at 4 millimeters of displacement. This is based on studies done in flexion extension by Inderbaum and Udelicht in the late 80s, I believe it was. So they used flexion extension X-rays as the gold standard, and they came up with a sensitivity of 0.88 and a specificity of 0.96 when the amount of displacement was at 4 millimeters rather than 3, which is the surgical threshold. Now, this 4 millimeters is below the level where the normal sized canal allows a cord to be compressed by that amount of displacement. So these patients would not be exhibiting spinal cord signs and symptoms. Because if you have spinal cord signs and symptoms, then you really shouldn't be doing any of this testing at all. This comes now down to imaging more than anything else. But we can convert those sensitivities into a positive likelihood ratio of 22 and a negative likelihood ratio of 1.125. So the 22, the positive likelihood ratio, is high, and it's a very definitive test. It's an excellent test for diagnosis. As far as the negative likelihood ratio is concerned, and that's excluding the diagnosis, then it's not very good. It's 0.125, and it's not great. You certainly won't have a lot of confidence in that result. Okay, so let's assume we know nothing about this patient. They've come in, we've got no indications they have an instability there, or they don't have an instability there. So what we can use now are prevalence values for the conditions that produce instability. In this case, the two big ones are ankylosing spondylitis and rheumatoid arthritis. Apparently, there are about 109,000 new cases a year of both. And the probability of coming across an undiagnosed case, which is what we're talking about, is about 0.440%. And the odds come in at about 0.0004 to 1. So there's not much chance of you picking up one of these. Now, we'll look at what happens when you start thinking about these numbers in terms of the presentation of the patient, just these prevalence numbers. Okay, so we have a prevalence value of 0.0004, which is going to be your initial probability. But let's add to that. Let's say there's a family history of rheumatoid. This increases the risk of the patient having rheumatoid by 3 to 5 times. So let's say it brings it up to a maximum of 4.4% after a positive test. Now, this becomes still very low odds. But remember why you're doing this. This is the risk that there is a craniovertebral instability present in the patient. And it's the risk is low, but the consequences are substantial. So that may be enough for you to say, okay, no, that's good enough for me. We've got a positive test. We've got enough indications that there's a possibility the patient has a disease. Let's get it out of here. Now, let's assume the patients are getting some symptoms, say chronic ongoing neck pain from trauma or from other conditions you don't know what they are. Then let's say those symptoms are enough to bring you up to a pre-test probability of 30%. It won't take much. Now your post-test probability is over 90%. Now you have a very positive test. So again, this all comes down to how likely the patient is to have the condition in the first place. Without the family history, without the symptoms, then the positive test, the chance of the positive test being a true positive is pretty close to 0. If, on the other hand, this raises much at all, the level of 5%, say, then you're going to start worrying about it. Once you've started higher numbers, this needs to go out quickly, simply because the consequences are so bad. Same thing would apply to, say, vertebral artery testing if we had these numbers, which we don't. But if we did, this is how we would apply the numbers to it. We'd be worried about even low probabilities of this being. We want almost 0 probability of the condition being present. So any probability is not really that acceptable. So let's go the other way now. Instead of things piling on, let's unpile them a bit. This patient, let's say we're doing a screening test. This happens all the time in classes. You end up with a positive test on students who have no indications that they have a condition that's going to produce instability up in the craniovertebral joints. And just to mention the fact that trauma is usually not a destabler of the craniovertebral joints other than fracturing it or possibly tearing the iliac ligament. But the transverse ligament almost never gets torn by trauma, usually ends up fracturing. However, you can have post-fracture stuff that leaves you with an ununited dense fracture, which allows the patient to move around, but nonetheless is completely unstable. But we're looking at any indication. So there's no trauma, there's no family history of disease, they haven't got any symptoms that will lead you to believe it. So now this will bring the anteriors down to a bundle, at least 10 times, probably 100 times, maybe even more. So let's just be conservative about this. Will it decrease the odds from the prevalence number down to 0.0004% from 0.0004%, 3 zeros versus 4 zeros. This will give you a posterior odds of 0.01%. This is 1/1000th of a chance of this condition being present in the light of a positive test. So again, if you're a worrier, then sure, send it back, but don't send it to the emergency room. This isn't necessary at all. Get the test redone, and if you're going to send it anyway, send it back to the GP. But the chances are you really don't need to do about it. There's a flaw in the way you're testing. There's something else going on here that will make this test positive when it simply shouldn't be. But it's unlikely that the condition that you think they've got or you thought they may have is no longer present. So there are two reasons to do a sharp PIRSA test. One is a screen where you expect to be negative. You expect the test to be negative because you don't believe the patient has that condition. And the other test is where you believe the condition might be present, just might be present, and you need to do the test to increase the odds of it being present, or get rid of it almost entirely, although the negative likelihood ratio isn't that great. But you expect this to be a negative test anyway. So it depends on why you're doing the test. These are the reasons you do any test, really, to rule it in or rule it out. But you need to know why you're trying to rule in and rule out. Ruling out is usually for about screening tests, high sensitivity. Ruling in is about diagnosing this, and the high specificity is more used. Now, how does it work, sharp PIRSA? Sharp PIRSA is a test you're doing to avoid major problems down the road, either from manipulation, exercise, or whatever, or another car accident, or the patient sneezing perhaps, but you're trying to avoid those problems down the road. So this is very much a screening test because you don't believe the patient has it. So now you've got a very low probability of being positive. So when you get a positive test, your post-test probability is very, very low. Now you can either ignore it, do something such as gather more information, or get somebody to retest it, or send it back to the physician. If you believe the patient has a test, you've got no odds on this. You don't want to retest this particularly, so it needs to go out. Now your own decision then is to go to the doctor, the GP, or does it go to the emergency room? And again, your anterior probability will give you an idea of which of the two it should be. So that it comes down to the post-test probability, not just a positive test. So as I've said before, positive test is not necessarily an urgent matter. It depends on what you thought going into the test, because that will give you the chances of it being actually present after the test. So if you're going in, you've got a low probability of it being positive, a low probability of being present, and the test ends up being positive anyway, the chances are that this is still a low probability after test number. On the other hand, if you go in thinking that the chances are the patient does have the problem and the test is positive, you have a higher pre-test probability and a higher post-test probability, and that's where you do something about it. Now, even if you increase the odds, the anterior odds by 10%, or to 10%, at 4 millimeters, you'll shift the probability of the disease being present to over 70%, and at 3 millimeters, it will still hit 65% or so. While the negative test gives 1.4 and 3.5 respectively. So that doesn't help a lot. It's still high enough for this test to be a real issue, but it's the negative test you should have less confidence in, which is good. You need higher confidence in a positive test because this is you're better off making a mistake on the bad side rather than the good side. So, in general, spin and snout are cute and they will stick in your memory, which is not a bad thing because it gives you a general idea of the value of each number in clinical use, but not about the value to the individual patient. That's a big deal. Statistics are all well and good, but it doesn't work on the individual patient unless that individual patient is completely average. Sensitivity and specificity numbers of the two tests don't necessarily give you an intuitive feel for what how good the test actually is. So likelihood ratio does do that, and if it's not in the paper you're reading, it's very easy to calculate from sensitivity and specificity values, and these are all look upable. I would strongly recommend Josh Clelland's book for this diagnostics, because he gives these things really quite clearly in his book. And the other one will be Chad Cook, who does much the same thing. Either one is worth looking at for this purpose. You need to estimate the odds or the probability going into the test. This is something you must do, and you need to get used to doing it, and you do it all the time. You should be able to, after you've done an exam, or before, like as soon as you've heard anything from the patient, what's your hypothesis? And you're picking that because it's the most likely diagnosis usually. And you test the hypothesis by more questions and more tests. So going in, you've got an idea of what this is. And this is test stacking, basically. So each test will increase the odds of a particular condition coming on. And you can work your way through it, providing each has likelihood ratios. So generate an estimate before going in. And the post test probability will give you how likely it is the patients will have the condition, not just based on spin and snout. So let's get rid of those two and kill them off for good, apart from an acute mnemonic that gives you a general idea about what each of these values do.